Heartburn after spicy food? Most people think that's normal acidity. But what if I told you that repeated acid reflux leads to esophagitis, strictures, Barrett's esophagus, and even CA esophagus? Today we'll understand GERD, Gastroesophageal Reflux Disease, from definition to pathology, clinical features, diagnosis, investigations, and even high yield exam points. And trust me, this topic is extremely important for exams and even clinical practice. So, what exactly is GERD? GERD stands for Gastroesophageal Reflux Disorder. Normally, food passes from the esophagus into the stomach, and then the lower esophageal sphincter or LES acts like a tight valve, preventing the backflow. In GERD, this barrier becomes weak or dysfunctional, allowing gastric contents to reflux back into the esophagus. And remember, GERD is not just simple heartburn, it affects nearly 10 to 20% of the population. So let's study the definition and epidemiology. According to Harrison's principle of internal medicine, GERD develops when reflux of gastric contents into the esophagus causes troublesome symptoms and or complications. The definition is important because not every reflux episode is GERD. Even healthy people can occasionally experience physiological reflux. It becomes GERD only when symptoms are troublesome or complications develop. Now let's understand the epidemiology. GERD prevalence in Western population is around 10 to 20%. Peak incidence is between the age of 40 to 60 years. There is a slight male predominance, especially in complicated diseases like Barrett's esophagus. Another important point, GERD is increasing in developed nations due to obesity, sedentary life, dietary habits, stress, and smoking. And clinically, GERD is usually chronic and relapsing. Now let's understand the most important part, that is the pathophysiology. This is the most important conceptual slide. Let's compare the normal mechanism versus GERD mechanism. Normally, the anti-reflux barrier depends on four major components. First, the lower esophageal sphincter or LES. A high pressure LES remains closed and prevents the reflux. Second, the diaphragmatic crura. The diaphragm provides external support to LES. Third, the angle of His. The acute angle acts like a flap valve. Fourth, esophageal clearance. Peristalsis and gravity help clear any refluxed acid. Together, these mechanisms prevent reflux. But in GERD, these protective mechanisms fail. And the most important is the transient LES relaxation, also called as TLESRs. This is actually the most tested concept in exam. Other mechanisms include reduced LES pressure, hiatus hernia, loss of angle of His, delayed gastric emptying, impaired esophageal clearance. As acid repeatedly refluxes into the esophagus, it damages the mucosa, leading to symptoms like heartburn, regurgitation. Over time, complications may develop, such as esophagitis, Barrett's esophagus, strictures. Risk factors contributing to GERD include increased intra-abdominal pressure, obesity, pregnancy, smoking, and even certain medications reduce the LES tone. Now let's study the clinical features. The typical or esophageal symptoms are: first, heartburn, a retrosternal burning sensation, usually after the meals or while lying down. Second, acid regurgitation. Patients complain of sour or bitter fluid coming into the mouth. Third, retrosternal chest pain, which may mimic a cardiac pain. Fourth, dysphagia, especially in advanced diseases or strictures. Now, many students forget the extra esophageal manifestations. GERD also presents with chronic cough, laryngitis or hoarseness, asthma like symptoms, dental erosions, and sleep disturbance. These occur because refluxed acid irritates the nearby structures. Now, very important, alarming features of the red flag: progressive dysphagia, weight loss, GI bleeding, persistent vomiting, iron deficiency anemia, new onset of symptoms after the age of 50. If any red flag is present, endoscopy becomes mandatory. And remember, GERD symptoms usually worsen after meals, on lying down, at night, or while bending forward. Diagnosis of GERD is often clinical. If a patient presents with classic symptoms without any alarming features, we usually start with an empirical PPI. Improvement with PPI strongly supports the GERD diagnosis, but if symptoms persist or alarming features are present, then further evaluation is needed. Now, the differential diagnosis is extremely important because chest discomfort can arise from many systems. Cardiac causes include angina, MI, pericarditis. GI differentials include peptic ulcer disease, biliary disease, and even pancreatitis. Respiratory causes include asthma and pneumonia. ENT causes include chronic sinusitis and postnasal drip, and esophageal disorders like echinacea cardia, CA esophagus, eosinophilic esophagitis. So, clinically, always rule out serious causes before labeling symptoms as simple GERD. Now, let's discuss the investigations. First and foremost, upper GI endoscopy. This visualizes esophagitis, ulcers, strictures, and the Barrett's esophagus. Indications include alarming features, chronic symptoms, refractory GERD, suspected complications. Second, 24-hour pH monitoring. This is gold standard for confirming acid reflux. It correlates the symptoms with the acid exposure. Third, esophageal manometry. This assesses the esophageal motility and lower esophageal sphincter function. It is especially useful before anti reflux surgery. Fourth, barium swallow. Useful for structural abnormalities like hiatus hernia, strictures, rings, etc. Fifth, impedance pH monitoring. This detects both acid and non acid reflux. Very useful in PPI non responders. So remember, no single test fits all patients. Investigations should be chosen based on the clinical scenario. Finally, let's quickly revise the high yield examples. Number 1, transient LES relaxations or TLESRs are the primary mechanism of GERD and not simply low LES pressure. Number 2, Barrett's esophagus requires endoscopic evidence and histological confirmation of intestinal metaplasia. This is very important for MCQs. Number 3, an empirical PPI trial for 8 weeks has a good sensitivity for GERD diagnosis. If symptoms don't improve, think of alternative diagnosis or non-acid reflux. Another important point, H2 blockers are less effective than PPIs. And in exams, if choosing between endoscopy and pH monitoring, endoscopy visualizes the complications, whereas pH monitoring confirms the acid exposure. So that was a complete overview of GERD, from pathology to investigations and examples. If you found this video useful, make sure to like the video, share it with your friends, and subscribe for more simplified medical concepts. Comment below what topic we should cover next.